So I'm going to talk about polypharmacy in a very, very broad way. I'm not trying to hijack this because this is about antipsychotics, but the two things are so intermingled and intertwined that they're very important. Polypharmacy is very important. So I can't even see those slides. So what is polypharmacy? Is it too many inappropriate medications? Too many appropriate medications? More than 5? More than 10? Well, we always struggle how to define it. And this is how I like to define it. It's when the theoretical benefit of multiple medications is outweighed by the negative benefits accrued from the sheer number of medications that people are on, regardless of the class of medication or the appropriateness thereof. So we know that polypharmacy is a standalone risk for morbidity. The average number of meds in residential care at the moment is 9, and those are essentially proper medications. We're not even counting the vitamins and all the different other stuff that people are on. We know that it decreases your global health, your cognitive function, and you get an increase in ADEs and risk of falls. So if you're on 5 or more, you have a 10% chance of going to acute care in a year. 7 or more, 20%, 9 or more, 30%. Some people say it's higher than that. And this leads to a phenomenon known as hospitalization-associated disability, which happens when folk, especially people with dementia or cognitive impairment, end up in hospital. A third of them come out very much worse than when they went in, even although their illness has been treated. So Dr. Doron Garfinkel, who kind of started this in Israel, figures that we should consider polypharmacy conceptually as a disease with more serious complications than the actual diseases that we're trying to treat. So how many people have seen a discharge summary like this? Admission diagnosis, delirium. Discharge diagnosis, urosepsis, as if. And then you get a problem list, usually referred to as the past medical history. And it's Alzheimer's, COPD, IHD, blah, blah, blah. But we never see this. These two other conditions that people have now, they have polypharmacy and hospitalization-associated disability. So when we do medication reviews, which everybody does, we still look at each individual drug and decide whether it's appropriate or not. And we forget about the inappropriateness of the actual number of medications that people are on. The chemoprevention that we employ, the statins and aspirin and all that stuff, it doesn't alter the all-cause mortality of people in residential care. They have a limited lifespan, and they are still going to move on no matter what you give them to prevent strokes or heart attacks or whatever. So all I'm really saying is when you're involved in a medication review, or there is a reason for doing a medication review, a resident's decline or a fall, as well as looking at the appropriateness of the medications, just count them as a starter and address it from there. And that is basically what I think we should do.